Hello and welcome everyone.
Hello,
Hi Nacho, how are you?
I'm fine. How are you?
Good. Happy to see all these eager optometrists wanting to join us for the evening. I'm just going to give it a few more seconds and then I will hand over to our guest presenter. Then we can have our discussion as well. Hello everyone. Welcome to our Academy Hour in the week when it's World Optometry Week. Okay. We are very lucky to have the President-elect for the World Council of Optometry, Dr. Cindy Tromans, to come and speak to us about the eyes to the future and how optometry can be improving global wellness. Okay. Cindy will do a short presentation about some of the data and figures that we have and policies that are being updated, and then we can have a discussion. We have a series of themes that we can discuss on after the presentation. So I shall hand you over to Cindy.
Good evening, everybody. Thank you so much for joining us tonight. It's really nice to see, I know so many of you on the call. This is absolutely fantastic. So some very familiar faces and friends on the call this evening. So I was delighted when I was approached by the Academy to have some time to speak to you in an Academy hour. So we have fortuitously arranged this for World Optometry Week, which started yesterday, and World Optometry Day is actually on Sunday this week. It's always the 23rd of March, and that falls on a Sunday. But we didn't want to disturb you on a Sunday, so we've put this webinar into the World Optometry Week itself. So as I've been introduced, I'm President-elect of the World Council of Optometry, and the WCO strapline for this World Optometry Week this year is Eyes to the Future, Optometry, Improving Global Wellness. So, yeah, we're going slow again. My slides will catch up with me at some point. Just bear with me. See if that works. Yes. Okay, we might have to do it the old-fashioned way. So just wanted to say just a few words about what WCO's key objectives are for World Optometry Week. So basically, we want to highlight optometry's impact and crucial role in global health and wellness. And we also want to celebrate optometry's contributions to increasing access to eye health as a human right. Obviously, one of the big things that we do is to advocate for increased integration of eye care into health systems around the world. And we also want to take the opportunity this week to educate patients and ensure that eye care remains a priority on the global health agenda. Again, my slide will catch up with me. Yeah. So what are WCO actually celebrating this week? So the top highlights from the work that the World Council are doing is that we are about to launch a new updated Why Optometry document. So this is an advocacy document for use by optometrists that want to advocate to their policymakers, governments, ministries, on the importance of optometry. I actually co-authored the original document back in 2015, but such a lot has happened over the last 10 years. So this is a really good time now to relaunch this document so that there is a good resource out there that explained why optometry, literally that's why we call it why optometry is so important. So we're also promoting exciting details about the Fifth World Congress of Optometry. So that's being held in June this year in Minneapolis. But we're also going to be, there's going to be a press release on the launch of WCO 6, which is our next World Congress, which is going to be held in 2026 in Riyadh in Saudi Arabia. So the official notice will come out either in the next couple of days, but certainly this week. But just so you know that that will be in the Eastern Mediterranean region, which we're really excited about. So we're also celebrating the fact that we've translated some of our key resources into different languages. You'll be seeing certainly on social media and also in some of the optical press around the world, various people popping up. I've done something for Optometry Today in the UK, and I know Sandy's also, who's on the call actually as well, as a fellow of the European Academy. She's the president of WCO, will also be doing stuff as well. So we're trying to really make it a lot of the media opportunities this week. So before I start, I just want to set just a little bit of global context. Now, I know many of you on this call will have seen all this stuff and know all this stuff, but I think it is still important to relate it back to really that seminal document, which was the World Report on Vision, which was published in 2019. It just seems such a long time ago now, but such a lot has happened since that document was published. And that really gave an idea of the true scale of blindness and preventable blindness across the world. And the figures that are still quoted today are, you know, there are at least 2.2 billion people in the world that are sight impaired. At least 1 billion of those, it's actually preventable due to causes such as uncorrected refractive error, presbyopia, glaucoma, diabetic retinopathy, cataract, etc. So all of this was taken into consideration by the World Health Organization, and they announced global targets for 2030, which was then adopted by a United Nations General Assembly. So this is really serious, high-level global resolutions. And the target that has been set is to increase 40% of effective coverage of refractive error by 2030. Now, we're already in 2025, so this is quite a challenge. So some of you may have heard of the World Health Organization SPECS 2030 initiative. Basically, that is to address that target. And I haven't got time to go into any detail of that this evening, but just to say that WCO are within the SPECS program, as are some of the members on this call, but we're fortunate enough to have, Sandy Block, Yazan Gamo, and our past president, Peter Hendicott, who are representing the World Council of Optometry and you by being on the work streams and working groups of the SPECS initiative. So as part of, in order to attain these targets, WHO has come up with a number of tools, and the ones that are really of main interest to us are the SCAT tool, Eye Care Situational Analysis tool, which essentially a country can use to say, look, where are we at? What are our eye care services like? What's our rate of blindness, this, that, and the other, and it sets the benchmark. So a country can assess where it is, and then obviously then come up with an eye care plan, a national eye health plan, or whatever, to try and reach those targets. But more importantly for us, it's the eye care competency framework, which the WHO published, which has been adopted by the World Council of Optometry, and I'll talk about that in a moment, really sets out, it's a different way of looking at how we treat eye care issues, problems, because no longer is it said an optician can do this, an optometrist can do that, an ophthalmologist can do that, an orthoptist can do that. It's basically competency based. So it's no longer what I would call a personal role based. It's based on competency. So it doesn't matter if you're an optometrist, you might be able to do some of the competencies that normally an ophthalmologist would do. As long as it's within your scope of competency, then that is absolutely fine. But I'm going to come back to that, so I'll not take too much longer talking about that. So what I want to try and do is put this into some kind of context, because this is what we want to talk about tonight, is what does this actually mean for opticians and optometrists? Well, the whole point of this is to get eye care embedded into universal health systems, and in particular primary care. Well, most opticians and optometrists, certainly in Europe, work in a primary care setting. We're on the doorstep, we're close to home, we look after people throughout their life course, and of course, we correct refractive error. That's one of our fundamentals. Supply optical appliances, rehabilitate in vision impairment, screen for sight-threatening diseases, and we can manage common eye conditions, and also manage or treat other conditions if we have therapeutic rights. So it's really important now that with all this happening and with all this going on, is that we actually look at what our professions are like and take stock. So the things that we need to consider: do we have an adequate workforce? Do we have the right skills, knowledge and competency sets? Are we recognised as a healthcare provider? Do we have the appropriate legislation and regulation? Is what we're doing now, is it fit for purpose, or do we need to change it? And obviously, with everything that we read and we know about the influence of technology and digital health, how's that going to change things? So I just wanted to, we have got some evidence of what our professions look like now. So we've got the Blue Book, which I was very heavily involved in, EQ Blue Book, published in 2020. That is now, we're just starting work on the next iteration of the Blue Book. But it does give us ideas about what scopes of practice, etc., are like over Europe. And also, building on the work of the Blue Book, the World Council of Optometry performed a global survey of optometry. And, this is the first publication that's highlighted here from that survey, and there will be others following along from that as well. So what are some of the key findings? So key findings from the Blue Book is not unsurprising. Standard eye examination is actually quite similar across Europe. But one very key feature is that the educational recognition is often higher than the legislative recognition, which obviously fits with the educate before you legislate. So you might be educated to use diagnostic drugs, you might be educated to use therapeutic drugs, but that doesn't mean to say you can actually use those in law. But the good thing is that what we highlighted in the 2020 Blue Book is that the scope of practicing is developing, in particular for the use of diagnostic and therapeutic agents. So that gives some encouragement to show that the profession is moving forward. So key findings from the Global Survey of Optometry. So this was just WCO members who were members between 22 and 23. So we had 39 countries. So interestingly, less than half of the countries met the recommended figure of 1 per 10,000 optometrists to the population. So obviously, that is significant. Also, optometry is not regulated in some countries. I'm not necessarily pointing fingers here, but this is the evidence, and in particularly in Europe, that we can see that that is a problem in France and Portugal. A third of countries don't require a bachelor's degree as a minimum. Diagnostic drugs is actually prohibited in 20% of countries, and at least a quarter limit the use of pharmaceuticals. So you can see, while there are some positives there, there's a lot to do across. Obviously, this is WCOM, so this is a more global perspective. There are certain themes there that can be picked out and obviously need to be worked upon. So, as I said, I was going to come back to the eye care competency framework. I'm not going to go through this in any detail at all, but it just gives you an idea of how the framework is set out. And just so I don't know whether you can see my cursor there, but optometry is considered to be in the 4 to 7 years. So is the advanced and expert level of higher education according to the WHO framework. But in order to distill this down and make it relevant to the profession of optometry, this is an absolutely brilliant document. WCO took this competency framework and have made it specifically relevant to optometry competencies. So it defines optometry in terms of the minimum essential competencies required to engage with this new agenda. Excuse me while I have a sip. As I said, this is available on the WCO website, so I'm not going to go in this in any detail, but it is for those of you that are working in educational establishments or thinking of rewriting a curriculum at any point in the future, this is really is a must read. So one of the problems is, how do we get recognition as a primary eye health care provider? Now, we know in Europe that this isn't always the case, that we're not necessarily always seen as eye care, as health care. So for example, it's seen more as a handicraft profession, or it's linked to physics or whatever. So we know that this is sometimes an issue in Europe, but there's lots of things that we can do to try and impress upon our policymakers to recognise optometry as a primary healthcare provider. But but it's all about developing a scope of practice to ensure that we have the necessary skills, legislation and regulation, and being licensed and registered health professionals. So this is where I think this is the hardest part. Unfortunately, when we have a lack of regulation, it does enable unregistered persons to engage without necessary training and oversight, which unfortunately can lead to poor quality services and negatively impact on professional advocacy. And again, we do see this happening across the world. And this is the reason why legislation and regulation are so important. And to address that, we, WCO, have developed a toolkit, which is a resource for members of WCO, which outline the steps to, what steps you can take to everything from setting up an association right the way through to it's in 3 stages. So stage 3 is extending your scope of practice, but all those stages with case studies. And again, it's a great resource, particularly in countries who are either very in early stages of setting up the profession or are struggling to get the right recognition or regulations in place. So one of the other things that we really need to critically look at going forwards is models of care. And this is very variable. It will depend on the scope of practice, It will depend on what other eye healthcare providers there are in your country. And I've just used the UK as an example here. And these figures are often used in the Blue Book as well. But in the UK, the last time I looked, there were 3,377 ophthalmologists, but we have 20,000 optometrists. So you can see there are far more optometrists than ophthalmologists. There aren't enough ophthalmologists to manage the eye care workload in the UK. Absolutely not. And that was one of the reasons why we successfully got recognition for therapeutics back in 2009. It's a long time ago now. It was quite a battle, but all these things need to be taken into context and used to be able to lobby for extended scope. I'm coming to the end of my my sort of preamble here. I want to just talk just very briefly about task shifting. Task shifting is really flavour of the decade with the World Health Organization. And basically, it means essentially redistribution of tasks among health workforce teams. So to put this into context of eye care, tasks that would be performed by an ophthalmologist, certainly in my experience working in a UK hospital, optometrists have been doing those for a long time now. And likewise, tasks that would be performed normally by optometrists are now performed by opticians, and other tasks by non-registered or assistant workforces. And you know, I think in a lot of countries across Europe, we actually see some of those core things like refractive error, etc., actually being managed by ophthalmologists. So it's like a reverse task shift. And that's kind of some of the things that we need to work on to make sure that those, if you have appropriate skills, you're doing appropriate tasks and can increase your scope of practice rather than decrease your scope of practice. So this is a whole talk in itself. So I'm not really, I've just put this in just because we have to recognize the influence of technology and digital health. And, you know, we know from COVID how that changed such a lot. It really did accelerate the use of digital health. So we also have to bear that in mind when we're considering our future models of practice. So I was only allowed to talk for 20 minutes. I've probably talked for 22 minutes, so sorry about that. Because what we wanted to use this hour for was really to have some discussion amongst the participants of the webinar around, you know, do you have any examples on models of care that you've changed to address eye care need in your country? Have you expanded your scope of practice? Have you managed to get any legislative change? Do you have any examples of task shifting or use of digital health and AI in eye care? So I'm going to leave it hanging at this point, and I think Rupal is going to field the discussion. So please feel free to come forwards with anything that you want to talk about. If you've got questions for me, if you want to share examples from your own organizations, countries, experiences, you know, that's what we want to use this session for. So back to you, Rupal.
Thank you, Cindy. I was having a computer issue, so luckily I joined at the right time.
I wondered where you gone. You disappeared off my screen, but you're back.
Yeah, I'm back. If you want to stop sharing and then we can open up. I guess my two big things from the questions you've raised is things across Europe, as you said, there's different scope of practice and there's different legislation. What do people think? How do we approach this unification of our scope of practice as eye care professionals? Is it about education? Is it about competencies? Is it about legislation? So I'm opening it up. I know we have a mix of educators as well as, I guess, advocates or politicians or legislative advisory colleagues amongst this group. So how do we open to everyone? If you want to put your hand up, unmute. Let's see what we've got. Sandra's put her comments on there, so we'll come to those as well. Who wants to go first? Gabrielle, I see, is trying to unmute. So I don't know if she wants to go first or not.
I was reading the comments of Sandra first because she's asking a question here. My glasses are not good enough anymore. Maybe what do you really want to know? Because I can share some examples of the Netherlands.
Yeah.
Maybe
So-
that's interesting.
I think that would be useful for other people to
Yeah.
know as to how Netherlands, I know a few years back, 15 years back when the academy was started, didn't have a lot of the ophthalmic drugs and stuff, but you've managed to move that forward. So how was that journey? What were the learning points on that journey?
In the Netherlands, it took a very long time. We started our lobby in the 80s of the previous decade. And in 2000, we had our recognition of the optometry, of optometry. And we were also able to use diagnostic drugs. But we were not in the healthcare system. So we had the opportunities to do a full eye exam with dilated fundus exam, but the health insurance will not pay for the exam. And in 2021, 1 week before 2020, 1 week before COVID, the lockdown, we had a consensus with the ophthalmologists and the patients organization that they agreed that optometrists will do a part of task shifting from the ophthalmologist to optometry. And then we found out that the legislation, so the law is not suitable to have optometry in the health insurance system. And it took us a very long time, and we have on political level a lot of other issues, some world issues like what's happening in Ukraine. So we are still waiting of our government what they decide if optometry will be in the healthcare system. And everything we are preparing now. So we have we are building a quality system. So there is some transparency about the quality of the optometrists, like visitation. Is it an English word? I'm not sure. I'm just
Whether they're healthcare, they can make decisions. Their health, they can advise on health or.
Yes, I know Sonia is also here, and her English is much better. So maybe Sonia can translate it.
Quality control, but I'm really ill, so.
Yeah, so governance, clinical governance, I'm guessing.
Governance, yes.
So we are still waiting for the government that they will say that we are in the healthcare system, and that means that patients do not pay for the exam. And hopefully we hear this in the next coming months, but we are waiting. Actually, we are waiting for 2-3 years already.
Can I ask a question? How, when the government or when politicians go out to change legislation, they consult, I'm guessing, with other health professionals and patients. Where was your biggest hurdle or a barrier? Was it patients feeling that they didn't trust optometrists, or was it other healthcare professionals who felt that you aren't educated or had the skills to the same level as they might have, and therefore you are not considered healthcare? Where was your who are your naysayers? I want to say the people that are saying no, and who are your supporters?
That's a very interesting and good question. It took us a few years. When I previously I was president of the Dutch Optometry Association, and when I started, the ophthalmologists were quite or very negative about optometry, and some ophthalmologists were also saying it in newspapers about our bad quality. So we started talking with them to know each other a bit better. And I was always also working in a hospital, and that was also very helpful during this time. So we knew each other already privately, and we know each other already what I can do, quite competences. So they were quite negative about our quality. We were. We saw our own weak points in our optometry also, that we had some differences in quality. So that's why we decided to develop a quality system where there is transparency in our own quality. So the things they were saying to us, we thought, okay, we can be angry that they are saying this to us, but let's look at ourselves and how can we change this idea about optometry and about us as a professional. And we discussed this also with the ophthalmologists and also with the public health department of the government. And then we were having a consensus together. This quality system is enough transparency. So if we did it a bit together, and that gave them also the feeling that they have some influence. And the other thing, a big issue was that optometry is placed in an optician shop. So we are selling glasses, and that we are influenced in our exam that we will not give a proper advice because we want to sell the glasses. And that's why we have that governance thing. It disturbed a bit, so I didn't hear the translation of the thing I was asking Sonja. Do you know, Pavel, what she said?
She was saying it's
Governance.
Yeah.
Governance. Okay.
Governance and quality assurance.
Okay. Yeah. So, and that's done by optometrists are looking at their colleagues. They are visiting them and look at their quality system, about their qualities, sorry. Yeah.
Okay.
So if I can just come in there just briefly, I think the whole, the point that you just made about how the profession is perceived, they are perceived as selling glasses,
Yes,
to appliances, rather than a healthcare provider, and that's why it is. And you just articulated beautifully what a challenge it is to get recognition as a healthcare provider. But if we're going to move the profession, this is one of the hurdles that we have to overcome. But there are also some areas of the world where they don't want to be a healthcare provider, because actually, thank you very much, we make a very nice living, and I'm just only saying what we know to be true, make a very nice living by just doing the basics and selling glasses. So it's not only a sell to our governments and policymakers, it's also a sell to our colleagues. I call myself an optometrist. I'm a consultant. I work in a huge eye hospital. I have a very expanded scope of practice. But then you have an optometrist that they just do very basic eye exams, and that's it. So it's how we kind of level up. And it's interesting in the article that just been providing some info for the Optometry Today article. And one of those questions were, why is it important that optometrists should work at their full scope of practice? That's exactly the point.
Yeah.
You know what I mean? And it's a bit like, I said in my presentation, ophthalmologists, why do we want ophthalmologists that just refract and prescribe glasses? It's kind of the same kind of thing. Anyway, I'll shut up and let Nacho have his say.
Go on, Nacho.
Hello, thank you very much. Thank you, Cindy, for your presentation. Well, in Spain, as you know, we are considered a healthcare profession. We are under a national law that describe us as a profession that it's in care of into the healthcare professions. But now recently we talked with the government to get into the system, the public system in primary care. And well, we had the strong opposition of the ophthalmologists already recently, last month. They organized a huge communication to media, saying to the government that we are, same arguments that Gabriel said, that we are not good prepared to do that we practice in a shop, like we are interested more in selling than in healthcare. And it's funny because in Spain, the competences, the legal regulations are given to the autonomous governments. The system in Spain is quite complicated because the national government gave the responsibility to the autonomous governments. And in some parts, in some regions of Spain, we already did some experiences, like, for instance, in Madrid, the government of Madrid, of the region of Madrid, that includes not only the city of Madrid, but also other cities in the region of Madrid. We made an agreement with them to check the eyes to kids, to small kids, and provide glasses for them. And the government is giving a certain amount of money, 50 euros per glasses prescribed, and they tell them to go to the optical establishments that are considered healthcare establishments. As you know, we have regulations, healthcare regulations for opening our shops or establishments. We are considered healthcare establishments, so we have a regulation in that too. But the ophthalmologists keep arguing to the government that we cannot use some terminology like prescribing. We cannot say patients because that's confusing for the population. Lately, we received a letter from the Ministry of Health, lately 2 weeks ago, from the Ministry of Health, saying that, well, we recommend you not to use the terminology about prescribing, about patients, about, things like that. Don't call your offices like clinics because you're establishments. So, ophthalmologists are still strong. It's funny because it's a similar situation that you put in your slide, Cindy. The amount of ophthalmologists in Spain are around 5,000, and we are more than 20,000. So, and we are all registered, and we have a regulation to practice in Spain. So it's not the case of not having optometrists not good trained. All the optometrists in Spain have to go through at the university in a degree, in an official degree. We have 15 schools, 15 universities giving the degree. So it's a funny situation, because I think it's because of the economical matters. Some ophthalmologists think they're going to lose their business if we are recognized in primary eye care. The system in Spain is more a public system. You get free tests in the Social Security. So if you go through an optical establishment, we usually didn't charge, but now most of our colleagues are starting to charge to make an examination, even though if you don't buy the glasses there, whatever. So I think we still have that opposition of the ophthalmologists. We are trying to talk with them in the same way that Gabriel commented, saying them, well, you don't have to be afraid. We are in the same ship. We're going to have a lot of baby boomers get retired soon, and they are going to be, very sensible with their eyes because they're going to need a good vision for doing activities that they will do more, intensively in their retirement. So we have to be prepared with that, and we're in the same ship. So let's talk and go together to get government. But we're having a huge opposition that we didn't have before. It's funny because it's going, it's rising that fight against us. Now that we make it, we know that it's clear that red line of pathology or, healthy eyes. We respect that line. We are not asking for therapeutic drugs. We are asking for optometry drugs, as you call optometry practice drugs, as we call it. We call them. But we're starting to have bigger opposition from ophthalmologists. Surprisingly, it's a surprise for us.
So now, before Daniela comes in, can I ask a question? Are the ophthalmologists also making money commercially from carrying out sight tests and prescribing glasses? It's the same commercial thing. So it's a matter of pushing that back to say, you trained for all these years to do health. It is where they're making money. Maybe don't call them patients, but call them service users.
The thing is that most of the ophthalmologists that are in the public system, in the afternoons, they have their private practice. And most of them are not surgery, don't get the money from surgery. Most of them get the money from, refraction. And people, they keep saying well, it's safer for you to go to ophthalmologist instead of going to an optometrist, because we know about, if you are sick or not, and optometrists don't know about that, So it's safer for you to go to the ophthalmologists, but they want them to go to their private practice,
one,
not to the public system. So the regional governments, because they are the ones that have to pay the public system, are with us, and that's the reason we are developing programs with them in public, and also getting some kind of recognition in primary eye care. But then the national government comes, influenced by the medical, power, and they say, well, be careful. We can regulate nationally also. Don't forget that, and start putting barriers. So we're in a funny moment now.
Daniela, you had a question? We can't hear you, Daniela.
Is this better?
Yes. Yeah.
Great. Sorry about that. Yes, I have questions, please, for Gabriel and Nacho, please. How is it with insurance in your countries? Are you already insured for patient care or seeing patient? And when you want to call your practice clinic, are there already regulations in place? Because normally these terminologies refer to specific quality regulations which have to be adhered to on a more global level within a state or a nation. Is this in place already in both of your countries? Or
Gabriela, do you want to go first, and then Nacho?
Yeah. The optometrists are in 2000 we are seen as a healthcare professional, and that means also that we have to follow some laws, but The only thing I was explaining is that we are not in the health insurance system, but all the other things are in the law as a healthcare professional. And the insurances for you as a professional, you have to take care of by yourself.
So if you would do medical neglect or something like that, you would be insured against that.
Yeah, you have to do by yourself to
Yeah.
insure it,
Yeah.
to take that kind of
Yeah.
insurance. Yeah.
Now, how is that in your country? Thank you, Gabriel.
In Spain, I think.
In Spain, we are not covered by the private insurances. The public system. We only have ophthalmologists being the ones that can develop eye tests, but in many hospitals, public hospitals, already work optometrists now. And optometrists now do the eye exams. Ophthalmologists only you check when they have to go through surgery or whatever, and optometrists do that work, but only under the public system. But in private, we are not covered by private insurances. In Spain, it's very common to have a private insurance because usually public service is slow, and if you need some test or whatever, they put you in a waiting list, and you have to wait for months. So people pay for private insurance, but they don't recognize our prescription. So
No, I meant your professional insurance, not the patient insurance. I meant you as a professional. If you as a professional can actually get insurance to practice healthcare or medical care.
So it's medical
insurance.
indemnity. So it's protected.
Yes.
Yes, we are protected. Yeah, we have through our organization, our professional organization. When you register, you have we give our colleagues an insurance. We pay for it. So the thing is that we are insured in our practice. So, but not the public system. No, the insurance we give is a private one, and for all the colleagues when they register.
That's interesting. I think that's interesting that you can actually insure yourself before you get regulated. So
we are regulated. We are regulated. We are professional regulated. So that's one of the things that government makes it obligatory for healthcare professionals to be insured. And to make it easier for our colleagues, we give that insurance through our professional organization, because it's compulsory. It's you have to be registered if you want to practice.
I'm asking because I'm originally trained in Germany, and since many years we have the same battles really, and we haven't achieved regulation in any shape or form. We were, I think, at some point very close, and then unfortunately, lobbying from the ophthalmology market was a bit too strong and has basically undermined all the efforts which have been done until then. One of the things I always find quite interesting is that very often these conversations before regulation is in place are done without any kind of health economic studies. So for me, the most interesting bit is really, okay, if we regulate, if we introduce another profession which increases the complexity of the health system to a certain extent, what is the actual benefit of that? And from my experience, having worked in very different settings around the globe by now, these conversations are very often held without proper evidence. There is a feeling and there is a drive and an intrinsic motivation to have this in place, but very often it lacks neutral evidence, and that gives the opposite or opponent a much, much better position.
I think, Daniela, we have some pilots. We have some pilots in the Netherlands where, because exactly what you say, optometry is a new profession in the healthcare system. And we did some pilots where you can see how many patients are sent to the ophthalmologist. So we are getting some data, and then we can show everybody that it's cheaper to have optometry in the eye care system, but also a less longer waiting time for patients. And this is not an official publication, and I think it will be very helpful, this kind of pilots, that there will be a publication in a good medical
Definitely.
magazine. Yeah.
Definitely. Cindy, I think that is something where the WCO really might want to provide some input, that we develop a global framework for health economics in optometry, because the societal impact is measurable if it is done properly. But I think it needs to have the same model applied to in each of the country to achieve harmonization, but also to achieve a solid foundation of evidence.
Okay, yeah, I'll certainly take that suggestion back. I mean, in terms of, I wasn't aware that there were any data for the sort of a whole profession sea change, but I think it's becoming more and more common now to, certainly when you're changing a model of care. So there are a number of examples now, aren't there, from the UK that have said, well, by shifting this from, ophthalmology down to optometry, this is how much money you can save. This is the benefits for the patient, this, that, and the other. And I'm just off the top of my head, I'm thinking about the COVID urgent eye care scheme, because I was involved in that. And that is a classic example of how a task was shifted, to answer Sandy's question, out of secondary care during COVID into primary care optometry practice. So, but I, to be honest, I'd not really thought of it as a sort of a sea change in terms of the impact of the whole profession. But I am going to go back and have a look at the WHO SCAT tool, because there might be something in there, because that's really for governments to use. I've got a feeling there is something about economics in there, but I don't want to say for definite. I'd have to go back. So, but yeah, that's an interesting dimension that I haven't included in presentations previously. But and as you say, we're fighting battles on a number of fronts. We're fighting with the policymakers, with the Ministry of Finance, and colleagues, and other professions in the eye care. So we need all the evidence that we can get. And I was just listening to what Nacho was saying about his battle with ophthalmology, and the problems that Gabriela described. I just wonder how much impact all of this WHO influence on eye care. And obviously, once you've got a United Nations resolution, if your country is a member of the UN, they are mandated to do these things. Yeah. But how much of that actually percolates down?
I think it is on us to do that. I think it is on us to align our efforts with the sustainability goals and actually make having eye care as a human right.
Yes.
And there is more than enough evidence out there that if we tackle eye care issues very early on, that education is better, poverty is less of a risk. Social mobility is there. So we have all the evidence, but
and that is exactly what we put in the Why Optometry document. Encapsulates all this, so it's just a one document that you can use to speak from. But no, I'm absolutely with you on that. And as you said, it's got to be a bottom up approach, hasn't it? It's got to come from the professions and from leadership. I haven't talked about leadership, but it's really important to have strong leadership to try and effect these changes. because you've got to really keep at it, as Gabriella will attest to. So you need that leadership. Yeah, it's got to come. You're right. It's got to come from us.
Yeah, Matthias.
Hi, everybody. Yeah, thank you, Cindy. Yeah, maybe I can only give a contribution, an example from a small country. So, with this task shifting, we have a bad example. Actually, they went the opposite side. The insurance companies, the government and insurance, they did not want to pay ophthalmologists their work properly, so they allow them rather to sell glasses than pay them more for the services. And that's really a bad example. But on the other side, all the private clinics, they are blossoming so much of the ophthalmologists that they had to employ optometrists. And now they give them so many more of competencies. We have optometrists, they regularly dilate. They sometimes subscribe the recipes for the therapeutics after cataract, for instance. For now, the standard ones you get for the 2 or 3 weeks after cataract surgery, but they do it. And then the new example of the ice cream project, you've all heard of probably. It's really a great example where ethical committee had to agree actually that we are doing OCTs on our own, which before it was, what are they doing? And now we have it official. Also, we did some projects where ethical committee, the medical ethical committee approved the use of dilation in several projects. I talked about the spaceflight simulants. We do it in our practice and we got allowance for that. Also for testing new instruments, we did trials with eye care, for instance. So these are examples where we got, for experimental purposes, the allowance, but it is there. So somebody at the medical committee already said it's okay at certain in certain setup. But so slowly, ophthalmologists are doing so well, so they are cutting their time of working, so they need to delegate. And we just have examples all over the place. And the new boss of the insurance company came to us and he said, we really want you on board. We want you to prescribe the glasses. There's still opposition from ophthalmologists, and now the major problem is we are not regulated. And the second, the idea about how much it would be worth to pay for optometrists to prescribe glasses is very low in the eyes of the insurance company, the health insurance. So most of colleagues would rather see this completely to abandon the glasses like Germany did years ago, and they would be more happy with that. So we are not sure what will happen in this way, but it looks good. So people are working. It's not regulated, but if you have mastery in optometry, you can actually work almost like an ophthalmologist. You can refer directly for cataract surgery. You are not shy to describe conditions like in Austria. Our colleagues, they are scared to death to use the word cataract or conjunctivitis, whatever. We do write this and we don't care, because if you are sure, if you are very confident in this, then you write it. I think that the things we have to report and can be used by other countries is do research, do projects where the door opens at least a little bit, and then you can showcase this is possible. Optometry does this. We got approval. We have ethics for this. And this might open the door on the longer run, even in Germany, I think. And I'm Germany trained, and I'm often a bit worried about the country. I mean, it's a big country, and optometrists are doing well, but on the long run, it's very tough how to change it. It's a lot of inertia there, really lots of inertia.
I think you just mentioned a really, really important point, and that's ethics when it comes to evidence. Unfortunately, most of the optometry research very, very often is not going through the proper channels to be considered scientific evidence at the end. And that really is a problem, because when it comes to actually discussing with politicians, with policymakers, with lawmakers, any kind of changes. You can have the most beautiful study in the world. If you don't have ethical approval, it doesn't matter. And that really is a downfall in a lot of countries I work with. I just came back from India, and I had a trip to China before, and it's everywhere the same. And I think one of the things we need to do as an academy and also the council is to really enable our colleagues to do research on a level that we can use it. And it is scrutinized properly and it is acknowledged properly.
Thank you, Daniela. I agree fully. And we had on the EVER meeting, European Vision and Eye Research, was in Valencia in the autumn. We had a section on this, how optometry can contribute to the holistic care and so on. And that was one of the points, actually. And there were many people, and there were many ophthalmologists present. And I think it's good we hear each other.
I think it's a topic for another time, but the number of researchers in optometry is now falling. We are not getting enough people taking up to do a PhD who are optometrists, who are not looking at some of these foundational theories, exploring AI use, evidence audits and stuff like that we have for, say, a Nachos pathway for children being seen in Madrid by optometrists. How are the patients feeling about that? All of that research we need clinicians to do. And yet the number of people applying to do research is falling across the world. And it's just, how can we still encourage that in an effective way, as Daniela says, with ethics, with publications coming out, which then helps us make our points to our policymakers as well. But I don't know if anyone else has noticed that number of PhD students are dropping in their countries.
Yes. Well, we are in the same country, so we have the same problem.
Right, but I know America has the same issue. That,
yes.
Again, it's not coming up. India has a lot of PhD students, but I'm not sure the governance of some of that research. If you go back to the point that we were talking about, is it done ethically? Was it, is the power calculation, the numbers, the statistics significant? Gabrielle.
In the Netherlands, it's very difficult to do a PhD as an optometrist because we don't have a master. And we are losing quite a lot of optometrists at the moment because after the optometry bachelor, they can become a physician assistant in ophthalmology. And in the end, the optometrist or that person doesn't feel his or herself an optometrist. And then we lose these people, and they have a master in physician assistant, and we have some Dutch optometrists who are doing the masters in England. But when they do their profession in our country, the job is still the same when they did the bachelor. So that's also a situation we are worried about in the Netherlands.
Yeah, I think we've had a very interesting discussion, and hopefully we've learned a lot, but it's a way forward. And I'm guessing we are all here as advocates for our profession. And task shifting, I would also add, maybe we need to consider our optician colleagues as well. So as ophthalmologists task shift to optometrists, then optometrists can task shift to our optician colleagues as well. I can't forget the second O in our name, so I have to just bring them back into our discussion as well. But it is about optometry this week. We are celebrating World Optometry, and Sunday is World Optometry Day. So let's go out and be proud of our profession and shout about how well we can play in the health economy for our nations. So thank you very much, everyone. Thank you very much, Cindy. for doing the presentation and setting the scene for our lovely discussion. Thank you everyone for your questions, for your comments. I hope you found this a useful hour, and we can always come back and have more discussions in May at the annual conference, which will be in Ljubljana. So please register, and hopefully we will see you there. And when we have our networking receptions, lunch and coffee, we can carry on our discussions.
Yeah, see you in Ljubljana, and thanks so much for the invite. It's been my absolute pleasure tonight to talk to you all. It's been really good. Thank you.
Thank you.
Thank you. See you in Ljubljana.